Hello? Hello? Hello?
So, yes, sir.
Now it is moving? Hello?
So we can see the first slide, so apart from that, nothing yet.
Now it is moving or not? Hello?
So you just could the IT people just upload the PPT to Teams so that we can see it later and you can continue with the class.
See, now we have uploaded. Can you see the slides moving?
So the slides aren't yet moving.
It's moving, huh? Hello?
No, sir.
It is not moving, madam?
No, sir.
ಅಪ್ಲೋಡ್ ಮಾಡಬೇಕಂತ ಮತ್ತೆ ಯಾಕೆ ಮೂವ್ ಆಗ್ತಿಲ್ಲ ಅಂತೀರ Hello? Hello? Hello?
Yes, sir. Yes, sir.
Can you see the movement of slides?
Yes, sir. Yes, sir. They're moving.
Yes, sir.
Now you can see.
Yes, sir.
Yes, sir.
Okay. Slide show. ಹೌದಾ ಅಲ್ಲ ಇದೆಲ್ಲ ಏನಾದರೂ ಇದು ಮಾಡೋಕ್ಕಾಗತ್ತಾ ಬಂತಲ್ಲ can I start from the beginning if you don't mind? Hello? Hello?
Yes, sir.
Can I start from the beginning because it is important from your future practice point of view also? Shall I start? Hello?
Sir, anything is fine, sir.
Okay, it may see now it will extend the time, that's the problem. Anyway, now you can see the movement of slides, is it? Okay, now I will start. See, today I am discussing about the rabies. The rabies is a fatal disease and it is a zoonotic disease that is caused by rabies virus, an RNA virus, Lissovirus genus, belonging to Lissovirus genus. See, the virus is present in the saliva of rabid animals and transmitted to humans following bite, scratch and lick. It is clinically presents as acute encephalomyelitis and patient usually survives for few days, and the disease almost always practically 100% fatal. No? That means once he gets the disease, the death is certain. So this is one of the example for the disease which has got 100% mortality. But you should also remember it is practically 100% preventable if timely and correct rabies prophylaxis is provided. That's why in order to prevent the rabies in rabid animal bite, the prophylaxis is very, very important. Now, regarding the epidemiology of rabies, globally about 60,000 human rabies deaths are reported annually. India alone reports about 20,000, that is, one third of these deaths annually, which works out to about 2 deaths per hour. The islands of Andaman and Lakshadweep are historically free from rabies. It is surprised to know that Lakshadweep is even free from dogs. An estimated 17.4 million animal bites occurs in India, and about 5 million rabies post-exposure prophylaxis are administered annually in India. Regarding animal reservoirs and vectors, see, the animals that transmits rabies to human in India are commonly dogs, which constitutes about 97% of the cases, and sometimes the cats, that is 2%, occasionally that is 1% by mongoose, jackal, fox, monkey, bear and other mammals. Consequently, exposure to these animals calls for rabies post-exposure prophylaxis. So, exposure to these animal bites, we have to give the post-exposure prophylaxis. You should also remember that animals that are ordinarily are not known to transmit rabies in India are bats, rabbits, squirrels and rodents. The bites from these animals will not require the post-exposure prophylaxis because they usually don't transmit the rabies. Now regarding the modes of transmission, the bites, it is bites from the infected animals commonly, and licks on broken skin or mucous membranes and scratches, rarely inhalation and organ transplantation from a rabid animal. As far as the pathogenesis is concerned, see, at that immediately after the bite of rabid animal bite, the saliva is infiltrated at the site of bite, where the saliva which contains the virus rabies viruses will multiply locally in muscle fibers. After multiplication, it travels to peripheral nerves and then to the dorsal root ganglion and to the spinal cord, from where it enters the brain. From the brain it comes to the salivary gland and other secretory organs. That's why so usually these viruses is present in the salivary glands, and the saliva of the rabid animal bite is the one which is responsible for transmission of the rabies. And you should also note that virus is neurotrophic, that is, it has got affinity to the nervous system, and there is no viremia in in the rabies. So this knowledge is important, because if you give a proper local treatment and if you infiltrate rabies immunoglobulin at the site of bite, you can prevent rabies or further progression of the disease and rabies. Regarding the disease onset, the incubation period, that is the time interval between the exposure to bite of a rabid animal and onset of clinical manifestation, is usually 3 weeks to 3 months, but varies from 4 days to 2 years. The bites on head, neck, hands and genitals have shorter incubation period. The children being shorter in size, less defensive, and more vulnerable to severe exposures to have short incubation periods. So that's why most of the time the children will be exposed to the category 3 bite, that is the what we call it as severe bites, because of the proximity. Now, as far as the clinical manifestations and outcome is concerned, it has got two types of rabies. That is, the common symptoms of classical rabies in 80% of the cases include hydrophobia, that is fear of drinking water, aerophobia, fear of breeze or air, and the photophobia, fear of light. In less frequent type of paralytic rabies, the patient does not have these symptoms and shows the signs of paralysis, most commonly in the bitten limb, and the condition usually is progressive. So anyway, in both the cases, the death is due to the death of rabies is mostly following cardiorespiratory failure. Now, after before the management of the animal bite, we should assess the risk of exposure to the rabies, and this can be discussed under three headings as per the WHO. One is category of exposure and the description in each category of exposure, and also what prophylaxis, post-exposure prophylaxis we should administer. So if you see the category 1, it is touching or feeding animals, licks on intact skin, contact of intact skin with secretions or excretions of rabid animal or the person, and this is considered as no exposure. Therefore, no post-exposure prophylaxis is required in category 1. As far as the category 2 is concerned, it is nibbling of uncovered skin, minor scratches or abrasion without bleeding. So which requires only anti-rabies vaccine, and this vaccine should be injected as soon as possible. Then the category 3, it is nothing but single or multiple transdermal bites or scratches, licks on broken skin, contamination of mucous membrane with saliva from licks, and exposure to bats. And here, since it is considered a severe bite, we should give the anti-rabies vaccine as well as the rabies immunoglobulins. Now, the latest rabies monoclonal antibodies are available in the market. This is replacing the rabies immunoglobulin, and this should be administered at distant sites as soon as possible, and immunoglobulins can be administered up to 7 days after injection of first dose of vaccine. See, what we usually do in category 3 bite, immediately after the local treatment, we give anti-rabies vaccine. Simultaneously, we infiltrate the rabies immunoglobulins as well as and the rabies immunoglobulins on the same day itself. Now, what about the laboratory diagnosis? See, the laboratory diagnosis is not mandatory in case of in managing the animal bite cases. This you should remember. Only for academic purposes, it may require the laboratory diagnosis, but as far as the management of animal bite cases, the laboratory diagnosis is not required. Now, what is the post-exposure prophylaxis in case of animal bite? The post-exposure prophylaxis is a three-pronged approach. All three carry equal importance and should be done simultaneously as per the categories of exposure. That means the importance of these three things are has got equal weightage. That is the local treatment of animal bite wounds, then active immunization with the anti-rabies vaccine, The third is passive immunization with the rabies monoclonal antibodies, which is available in the trade name of rabies shield nowadays, or the rabies immunoglobulins. It can be either equine rabies immunoglobulin or the human rabies immunoglobulin. Now we will discuss one by one. Now, the local treatment of animal bite wounds, the what we have to do is the wound should be toileted, or wound should be washed uh, thoroughly, and washing with soap or detergents, and flushing the wound with the running water. See, the wound should be washed thoroughly with soap and water or any detergent, the particularly with the running water, that is keeping the wound keeping the affected wound under a tap running under the tap. See, that is very important, which will remove the majority or most of the viruses at the site of bite. Thereby we can reduce the chances of getting the rabies in an rabid animal bite. If the soap and detergents are not immediately available, they wash at least with running water. The maximum benefit of wound washing is obtained when fresh wound is cleaned immediately. So, considering this wound washing as an important step, all health facilities or anti-rabies clinics should have wound washing facilities. They usually have the attached washroom where there is a tap with a running water and a soap and detergents to give a local treatment in any anti-rabies clinic. Now, after wound washing, the wound should be dried, and any of the available chemical virucidal agents should be applied, such as povidone iodine, alcohol, etc. Even common household antiseptics like Dettol or Savlon would suffice. See, even if you have Dettol or Savlon at your home or at your house, you can apply this after wound washing. This will help to inactivate the viruses at the site of bite. Now there are certain do's and don'ts. What are the do's? Wound under running tap water with soap for 5 times over the period of 15 minutes is very essential, and disinfectant and the wound should be applied with povidone iodine or spirit. And as far as the suturing is concerned, 1 or 2 loose sutures only if required, and only after the administration of rabies immunoglobulin or the rabies monoclonal antibodies should be applied. So, as far as the possible, suturing should be avoided. If at all it is required, under the cover of the rabies immunoglobulin, that means after infiltrating the rabies immunoglobulin around the wound and to the base of the wound, you can apply the suture. Otherwise, that too when the bleeding cannot be stopped. Otherwise, the suturing should not be applied, or the suturing should be postponed. The simple or non-occlusive dressings can be done if required. There again, the dressing should be avoided. Only when it is required, you can put the non-occlusive dressing. But as far as possible, suturing and dressing will be avoided in most of the cases unless it is required. Next is they give the tetanus toxoid and antibiotics appropriately depending upon the case. Then there are certain don'ts. That means you should not apply any irritants like chili powder, plant sap, lime, atta, and the jackfruit juice, etc. And you should not also cauterize because it damages at the site, the skin at the site of bite. Now, regarding active immunization, see intramuscular or SN regimen, active immunization is done with the anti-rabies vaccine. So here we are having the different regimens. The intramuscular regimen is otherwise known as SN regimen. Here the schedule consists of administering one dose of vaccine by intramuscular route in the alternate deltoid region. See, it should be given to the deltoid region. It should never be given to the gluteal region. In case of children, it should be given to the anterolateral aspect of thigh. So, each vaccine should be given on day 0, 3, 7, 14 and day 28. The day on which you are administering the vaccine is considered as the day 0, not the day of the bite of the animal. Now we are also having this intradermal or updated thigh Red Cross regimen. The schedule consists of administering one dose of vaccine, that is 0.1 ml into two sites, that by intradermal route in the alternate deltoids on the day 0, 3, 7 and 28. See here on day 14 we are not giving vaccine. So it is only the 4 visits, 4 into 2, 8, uh, 8 sites vaccine is administered. See here, what you should remember is Rabivax S is a modern purified virocell rabies vaccine, that is 1 ml. It comes in 1 ml pack, developed and produced by Serum Institute of India, Pune, is safe, pure and efficacious, and it is approved for use by both intramuscular and intradermal routes. But the other vaccines we usually give intramuscularly. No? Only few vaccines are recommended for intradermal routes, which is recommended by the WHO. So it is this Rabivax is approved by Drug Control General of India, that is DCI, and Central Drugs Standard Control Organization, Government of India, and is manufactured as per the recommendations of WHO. So these are some modern rabies vaccines that are available in India, that is Rabipur by Chiron, then Virorab by Ranbaxy, Abirab, Vaxirab, and all these things. So this will be useful for you whenever you want to treat animal bite or when you want to give the post-exposure prophylaxis with anti-rabies vaccine. Now, see here the intradermal administration. See, if you see this picture here, the see the dermis. Usually we have epidermis, dermis, subcutaneous region, and next to that is the muscles. So if you want to give intramuscularly, you should give at 90-degree angle, and for subcutaneous it should be 45-degree angle, and intradermal it should be 10 to 15-degree angle. You have to go parallel to the skin and raise the skin and administer between dermis and epidermis, that is intradermal administration. See how you will know that whether you are in a intradermal pain or not. See, you will feel lot of resistance when you are injecting, because and you will get the puckering like this one, pudding orange type of this one. See the you can see this. This is the diagrammatic representation of the various regimens that is given in the post-exposure prophylaxis. See, it's a SN schedule. You can see here the we are giving the vaccines, the 5 doses in 5 visits, 1 IM dose of vaccine on days 0, 3, 7, 14 and 28. The vaccine should be administered intramuscularly in deltoid region, to the deltoid region or anterolateral aspect of thigh only in case of children, and it should never ever should be given to the gluteal region, because if you give to the gluteal region, the absorption gets delayed and thereby the production of antibodies will get delayed, and thereby even if you give the vaccine, there are chances that the person may get rabies in spite of giving vaccine. That's why please give this vaccine intramuscularly to the deltoid region only. Then the next is intradermal regimen. You can see it is 8 doses, 4 visits. That is 2 into zero point 0.1 ml on day 0, 3, 7 and 28. And the injection of this 0.1 ml of reconstituted vaccine per intradermal site and 2 sites per visit, and 1 in each deltoid region should be given whenever he comes for the intradermal regimen. Here the advantage of giving intradermal regimen, you can save it is cost effective, that is you can save the money, because in one vial you can complete the in the 2 vials itself you can complete the schedule. Now this is WHO category 3 exposures. So you can see the multiple bites on the back and on the chin and also over the back side of the knee joint. So the passive immunization consists of either administration of human rabies immunoglobulins, that is the dose is 20 international units per kg body weight up to a maximum of 3000 international units, and the next is the rabies monoclonal antibodies. This is the new one that is available, and the dose is 3.33 international units per kg body weight, a maximum of 6.25 ml, that is 250 international units. And equine rabies immunoglobulin, the point is double the human rabies immunoglobulin dose, that is 40 international units per kg body weight, maximum of 3000 international unit. So here, sorry, this is the printing mistake. In human rabies immunoglobulin, the maximum dose is 1500 international units. So when you want to give equine rabies immunoglobulin, and this must be administered only after the test dose, because it is a heterologous serum which is prepared out of the horse serum. So the chances of reactions are high. That's why we must give the test dose and then give the full dose after the test dose if it is negative. See, follow the manufacturer guidelines for the test dose and inject 0.1 ml of 1 in 10 dilution of equine rabies immunoglobulin in normal saline, and it should be given intradermally over the flexor aspect of the forearm. And observe for wheal, erythema, induration, itching or tachycardia, and follow blood pressure and febrile pulse. In case of positive reaction, if the induration is more than 10 millimeter with or without constitutional symptoms, it is considered as positive. And in case of positive reaction, if we can give human rabies immunoglobulin or the rabies monoclonal antibodies is given depending upon the affordability of the patient and availability. Because here it is a homologous serum and it is prepared out of human beings, there will not be any reaction, so you can straight away give if he is allergic to equine rabies immunoglobulin, which is cheaper. So otherwise, if the patient can affordable and if it is available at that place, you can prefer to give the human rabies immunoglobulin or rabies monoclonal antibodies. If the equine rabies immunoglobulin has to be administered, then give the pre-treatment with adrenaline or epinephrine and with antihistamine before administering the full dose. Please note, a negative test is not guaranteed with an anaphylaxis that will occur. That's why we have to prepare for the reaction whenever you are giving the equine rabies immunoglobulin, even if it is negative. That is very important. See, the recent World Health Organization recommendation states that there is no scientific grounds for performing a skin test prior to the administering equine rabies immunoglobulin, because the testing does not predict reactions and it should be given whatever the results of the test. So the treating physician must be prepared to manage anaphylaxis, which, although rare, could occur during any stage of administration, even if it is negative. If it is positive, of course, we are giving pre-treatment and administering the entire dose. Then regarding passive immunization, rabies immunoglobulin or rabies monoclonal antibodies is the most effective when administered locally and early. The infiltration as much as possible, infiltrate as much as possible into and around the wounds. The remaining, if any, should be given intramuscularly at the site away from the site where the vaccine has been administered. That means it should not be given at the site of vaccination. So it should be away from the intramuscular vaccine administration. So inject rabies immunoglobulin or rabies monoclonal antibodies into all bones that is anatomically visible, and if rabies immunoglobulin or rabies monoclonal antibodies is insufficient by volume to infiltrate all the wounds. See, you have to infiltrate all the wounds, so you have to dilate it with the sterile normal saline to the required volume, and then it should be infiltrated to all the bite wounds. See, in case of when you want to give the equine rabies immunoglobulin, it must be administered with full precautions, because you may get the reactions at any stage of administration. This is the infiltration of wounds with rabies immunoglobulin or the rabies monoclonal antibodies. It has to be infiltrated around the wound and to the base of the wound or animal bite. See, what is the importance of RIG or rabies immunoglobulin or the rabies monoclonal infiltration? Why we should give, particularly in category 3. See, the incubation period will be shorter in category 3 exposures, especially when the bites are on the head, neck, face and hands, because the head, neck, face is nearer to the brain. The hands is the most active part in our body, so the viruses travel fast from the hands to the brain. That's why the incubation period is short. So when the anti-rabies vaccine is used alone, the patient are vulnerable to develop the rabies during window period of 7 to 14 days, because it takes at least a minimum of 14 days for the development of antibodies. So giving anti-rabies vaccine alone will not protect the individual in case of severe bite, because the incubation period is very short. So he may develop the disease before the antibodies are developed. That's why we should give rabies immunoglobulins or the rabies monoclonal antibodies and simultaneously give the anti-rabies vaccine to prevent the rabies. Now, the rabies immunoglobulin or rabies monoclonal antibodies are always used along with the rabies vaccine as early as possible and never be used alone to treat the animal bite victims. A full course of vaccination should follow through the cleaning of wound and passive immunization. So all the things has to be done simultaneously. That is local treatment in case of category 3, local treatment, active immunization and passive immunization. All three things has to be done simultaneously in category 3 bite to prevent rabies. Otherwise, the patient may land up with rabies. So these are some of the human rabies immunoglobulins and equine rabies immunoglobulins that are available in the market. And the difference is the human rabies immunoglobulin is the homologous serum, so no reaction, so no test dose is required. In equine rabies immunoglobulin, and it is costly, whereas equine rabies immunoglobulin is cheaper compared to human rabies immunoglobulin, but it is a heterologous serum, so the reactions are common. you have to do the test dose and then you have to administer it. So this is the latest the ready-made antibody that are available now in the market, that is rabies human monoclonal antibodies, which is much superior even to human rabies immunoglobulin, and now we are replacing the human rabies immunoglobulin or equine rabies immunoglobulin if the patient can afford with the rabies human monoclonal antibodies. It has got several advantages. See, this is manufactured in hamster ovary cell by recombinant technology, and it is a human monoclonal antibody. It neutralizes a wide variety of terrestrial and bat isolates of rabies virus worldwide, including all rabies virus isolates in India. So that's why it is much superior compared to the rabies immunoglobulins that are available in the market. It must be used in combination with a commercially available rabies vaccine and injected at sites separate from the rabies vaccine for post-exposure prophylaxis. So this I have already discussed. The safety wise also, there are only few local events here, pain, redness and swelling. It is mild in nature and it disappears after some time. Even systemic reactions also mild to moderate, and all will be resolved without any further treatment. See the advantages of recombinant rabies monoclonal antibodies. See, this is important. Here it is improved because it has got improved safety because no transmission of bloodborne pathogens, and expanded availability, unlimited production capacity, and consistency in the production that is well characterized, consistent. Definitely it is more potent compared to rabies immunoglobulins. The concentration wise also, see, if you want to give rabies immunoglobulins, the volume is more, that is 10 ml you have to give the maximum dose, whereas in case of rabies monoclonal antibodies, it is only 6.25 ml is the maximum dose, so it is concentrated one, and it is less voluminous to administer locally when you want to give. So these are the several advantages of recombinant rabies the monoclonal antibodies compared to the human rabies immunoglobulin and equine rabies immunoglobulin. Now, what are the special circumstances where you have to give the post-exposure prophylaxis? The post-exposure treatment should be given to immune-compromised patients, that is AIDS, long-term steroid therapy, chloroquine treatment, and anti-cancer therapy and immunosuppressive therapy, etc. See, persons consuming raw milk of rabid animals, you have to give the complete post-exposure prophylaxis. Please remember, pregnancy and lactation are not contraindications for post-exposure prophylaxis in case of exposure to the animal bite. This you have to remember. What about re-exposure prophylaxis? See, if the person is again exposed to the animal bite, if he has received either full course of pre-exposure vaccination or post-exposure vaccination, the following re-exposure rabies or rabid animal, following re-exposure rabies or rabid animal bite, he or she shall receive only 2 doses of rabies vaccination, either intradermal or the intramuscular, on day 0 and day 3. In such cases, the rabies monoclonal antibodies or rabies immunoglobulins are not indicated. That means if the person has already taken the complete course of vaccine when during the previous animal bite, if he exposed to the animal bite again, irrespective of duration between the previous vaccination bite and previous vaccination to the present bite, we can give only 2 doses of anti-rabies vaccine, that is on day 0 and day 3, that's all. There is no need to give the rabies immunoglobulins or rabies monoclonal antibodies. In case of re-exposure, again if he is bitten and if he has already taken the complete course of pre-exposure or post-exposure vaccination earlier. This is very, very important. Only 2 doses required. No RIG and rabies monoclonal antibodies. What about pre-exposure vaccination? See, it is recommended for risk groups like veterinarians, laboratory personnel working with rabies virus, medical and paramedical personnel treating the rabies patients, and dog catchers or dog pound workers, forest staff, zookeepers, and postmen, policemen, courier boys, children in canine rabies endemic areas. So the pre-exposure prophylaxis is required for these people because of high risk. What is the dose? See, the dose is 0.5 ml or 1 ml, whichever vaccine that is available. It should be given IM, or if you want to give intradermal, 0.1 ml of the vaccine is given on day 0, day 7 and day 28. So now the Indian Association of Pediatrics IAP has recommended the pre-exposure prophylaxis for all the children, and they want to give under UIP. See, this is the guidelines. See, why children should get pre-exposure vaccination. See, this is important because they play in the streets unsupervised and more number of stray dogs are available, so which can bite at any time. The children, because they are more accessible. And then short height, the head and neck or upper extremities are easily accessible to biting animal. So short incubation periods, though they are more prone for development of or contract rabies. Poor reporting to the parents because of the scare that they may scold them or guardians about these exposures. Poor knowledge of outcome and soft skin, even minor wounds may result in category 3 exposure. It is cost effective because of non-availability and non-affordability of non-accessible RIG or ARS. So re-exposures are common in case of children. That's why they require this pre-exposure prophylaxis, and this is important for children. Then what is the medical advice you should give to the patients? So there is, when you are giving this modern vaccines, that is the cell culture vaccines, here there is no diet restrictions, no restrictions of physical exercise. Report adverse effects, if any, to the physician without fail. Best to avoid consumption of alcohol during course of treatment. Complete the course of vaccination. So these are the things which you should advise to the patient whenever he comes for the post-exposure prophylaxis. Thank you. If there is any questions, I am happy to answer. Can all of you are hearing? Hello? Hello?
Yes,
Yes,
sir.
sir, we can
Yes.
hear you.
Yes, okay. So there was no problems, is it?
No,
Hello?
sir, not now.
Okay. Thank you. If you have any questions, you can ask
Thank
me. Uh, any questions?
Nothing yet, sir. Thank you.
Thank you. Okay. Sorry for the delay in technical errors. Okay. Thank you.